Hi, everybody. I'm Dr. Lisa Port, the Chief of Breast Surgery at Mount Sinai and Director of the Dubin Breast Center. Thrilled to be here in Aspen with my colleague, Dr. Monica Kraft. She will introduce herself.
Hello, everyone. I'm Dr. Monica Kraft. I'm the Assistant Chair of the Department of Medicine at the Icahn School of Medicine at Mount Sinai. I'm also a practicing pulmonologist and do research in asthma.
I'd love to ask you a few questions. Asthma is one of the most common diseases to affect people in this country. Nearly 26 million people in the United States have asthma. Why is it so common? And what can be done to reduce the number of cases
Sure.
we see?
Really good question. It is the most common respiratory disease worldwide. And so I think probably all of us know someone with asthma. And it's sort of been touted as a mild disease, but actually it's anything but that. There is a significant portion of patients with asthma who have very severe disease, where it affects daily life, going to emergency departments, hospitalizations. And so there's a real unmet need, and especially among specific race and ethnic groups. We can talk about that a little bit later. I think the reason that it's increasing is multifactorial. We're spending a lot more time in our well-insulated homes, and we're exposed to allergens, whether it be house dust mite, mold, or other allergens, depending on where we live, in terms of pollens, things like that. Also, air quality is changing, and there's actually an interesting interaction between climate change and propensity to have allergy. And so that then increases the prevalence of asthma. And then there's also different kinds of asthma, because it's not a one-size-fits-all, and there's an asthma that happens later in life that's associated with obesity. And then that's become, unfortunately, a rampant epidemic in our country, and also responsible for other what we call phenotypes of asthma. So I think there are multiple reasons.
Multifactorial, as with many diseases.
Yes.
Monica, what new treatments are available for asthma, and how can these help patients? What are the innovations taking off on that we can expect in the future?
Right. Well, good news, the immunology of the disease has really improved. And so actually, it's a great time to be in this space, because we have lots of opportunities, lots of treatments to offer our patients, many more than when I got into the field about 20 years ago. So from an inhaled perspective, certainly we know that inflammation, redness, and swelling of the airways are just really key aspect of asthma. And so our treatments really focus on that. So we use inhaled corticosteroids, which have been around for a long time. We have bronchodilators that are long-acting. We're starting to alter how we give them. And so now we're moving to what's called smart therapy, where, yes, a patient might use an inhaled steroid bronchodilator combination regularly, but then also use it as needed. So they need one inhaler for all their needs. So you're not carrying a lot of different inhalers around. You need anytime you need an extra inhaler because you're having symptoms, you get a little bit of an inhaled steroid as well. So it reduces that inflammation. So that's been a nice move, I think, especially for mild to moderate asthma. As we move towards severe asthma, we've really understood that there are these phenotypes, these different kinds of severe asthma, driven by specific inflammatory pathways. And now we have biologics that actually target those, and we have 6 at our disposal. And so patients need to have certain characteristics to qualify to have the best response to these biologics. And so it's an exciting time to have that ability. So we do a lot of phenotyping in our clinic. We try to really teach our primary care colleagues. I feel like that's a really important partnership in terms of making sure they're clear on how to diagnose asthma, when to know it's severe, when to refer to their friendly allergist or pulmonologist, and how it is a real partnership, working together to do that.
And with those innovations with 6 drugs, you see a patient, can you pick and choose and predict who will respond to what? Or is it really trial and error?
Well, we've developed sort of an algorithm based on certain biomarkers. Like, for example, the eosinophil, which is a white cell associated in the blood, it's in the lung, associated with allergy. In patients who have asthma and elevated eosinophils, they're eligible potentially for at least 4 or 5 biologics, so that's good. But they have to have other characteristics too. So we take into account their allergy history. So we'll measure IgE, we'll measure their response to allergens to get a very good sense of whether allergy is driving their asthma. We'll look at age of onset. That's actually a key feature in terms of how we think they'll respond to one biologic versus another. And then we'll look at other biomarkers we use in the clinic, such as we can measure exhaled nitric oxide in breath to capture untreated inflammation, certain measures of untreated inflammation. So we put that all together, and I'm part of Up-to-Date function editor, and so with colleagues, we put together an algorithm about how to navigate based on these characteristics, biomarkers, and age of onset to try to sort out what's the best biologic for your patient.
So you can really customize
That get to that.
That's amazing.
See, I did.
Why does the high rate of asthma in the U.S. fall disproportionately on people with lower income, older adults, and Black and Hispanic people? Why does that happen?
Right. This is a real issue, and it's something that those of us in our asthma community are really taking a close look at, because we feel that there's other factors beyond certainly allergy. There's also exposures in the home, and there's also access to nutrition, access to healthcare. There's health literacy. There's the microbiome that can actually differ depending on where you live and your propensity to live near highways, busy areas in terms of the air quality side. So we feel like there's a lot of different environmental conditions that are partly responsible. We've also done some work in that there's also different ways that different races, ethnicities respond to asthma medications. And so we need to understand that, those who better choose treatments for our patients. Again, along the lines of precision medicine.
Yeah, shit, have to.
And then the last thing I would say is the biologics are an expensive type of therapy, and unfortunately there's access issues behind those biologics, which is very frustrating for me as a provider.
Sure.
But thankfully I've learned a lot about how to make sure my patients can have access, but it's a
level to play.
Yeah, but it is a challenge. That's the other one.
Yeah, it's amazing. How common is it for asthma to develop later in life, the time that you described earlier, and why does that happen?
There's early onset asthma, which is probably the asthma that most people are familiar with, associated with allergy, allergic rhinitis, maybe atopic dermatitis, starts in childhood, and persists. Then later in life, it could be in the 30s, it can be in the 50s. Much more common in women to develop a type of asthma that can be very difficult to treat. Sometimes associated with that eosinophil, with sinus disease, nasal polyps, and we have biologics for that. Then sometimes it can be not associated with eosinophils, associated with metabolic syndrome, obesity, that side of the coin. And that asthma can come on later in life and also be very difficult to control. And we're doing a lot of trials right now looking at specific therapies for that type of asthma, because we don't have a biologic ready at the present time, but there are many under study right now, so the future's bright there too.
Anything else you want to tell us about asthma? It's fascinating.
So I think that asthma, it's very heterogeneous. It's not one size fits all, so that it can have asthma, especially more on the severe end, but even mild to moderate. Sure that you get a lot of information from your provider, and ideally, if you feel like, despite the therapies that you're getting, your asthma is still not well controlled, then it would be time to see a specialist and see what other options are available.
As always. Well, thank you so much. So enlightening, and it's so interesting, that there's so much optimism in a field that affects so many people in this country.
Well, thank you for having me.